I'm delighted to introduce our first speaker, Pat Murray, who's going to talk about early detection of drug-induced acute kidney injury.
Very good. Thank you, Samira. I hope you can see that far. It's good. So, welcome back from lunch. I hope you all got some. I want to thank the organizers for inviting me to speak on this topic. I'll try and go through it quickly and keep us on time. And what the topic is basically about a subset of AKI. In fact, it's a subset of CKD as well, as I'll point out. And I've got some relevant conflicts, and they're in the program and they haven't changed very much. But the big point of the presentation is that drug-associated AKI is not the same as drug-induced kidney injury. We're going to talk about the usual 2x2 approach to differentiating one versus the other. So I'll make comments about all these quadrants, but it's the same comments that could apply to contrast-associated AKI is not the same as contrast-induced kidney injury. The first quadrant we'll dispense with quickly. It's actually renal health. It's the absence of dysfunction and the absence of damage, which are sometimes associated with serum creatinine increases. Classically, as you know, trimethoprim and cimetidine. And we've tried to publish in several papers an analysis that sorted out whether you had pseudo-AKI as well because of blocking creatinine secretion with vancomycin and piptazobactam. We still haven't figured it out because there's not enough data collecting cystatins, for example, to sort out the issues. So we're going to leave the pseudo-AKI group aside for the moment. In functional AKI, we've made a lot of progress, actually. We've got better markers of kidney function and more coming. But we've also got markers that show kidney damage quite well. And the absence of kidney damage in these settings where the creatinine is increased is good evidence with negative predictive value of a pure dysfunctional syndrome. And in fact, we've now got quite a list of them. You know, in the SPRINT trial, hypertension controlled to normal levels, cause and incidence of AKI, which was biomarker negative. ACE and ARBs have been known to do this for years, both in heart failure and CKD. Acute heart failure, well, we'll talk about a little bit more. And SGLT2s actually are so commonly doing this by decreasing filtration fraction that we don't even check anymore to see if there's a creatinine increase. In hepatorenal syndrome, I think there's enough data to say there is a subset who have pure functional AKI with profound vasoconstriction, and they don't have damage markers in some of those cases, and they probably will respond best, as Mitra said this morning, to vasoconstrictor therapy. We added to the literature during the year on acute heart failure and AKI, and my PhD student and fellow Stephen Duff, who did this work, published it before he goes on with his critical care career. We measured, I think, a good array of damage and dysfunction markers in our lab in patients in the akinesis trial who had AKI in the setting of acute heart failure. And I think even most of us will find one of our favorites in there. And when we looked at the tertiles and adjusted odds ratios for who progressed to a higher stage of AKI and acute heart failure, there just isn't kidney damage in this syndrome. It's a functional syndrome. We found one marker, galectin, that actually was independently associated in adjusted analysis with progression of acute heart failure AKI. And I think there may be something to that. It's a marker of fibrosis and inflammation, but it may also be spurious because of the number of things we've checked. So we'll go back to that. But I think it's fair to say that given that we know that congestion is the issue in heart failure, unless proven that there's kidney damage that's emerged because you're doing aggressive fluid removal, you should just keep doing decongestion as long as there's any evidence of extra fluid on board. And in fact, it's the congestion markers that are relevant, not the kidney markers, except if you've overdone it or added an nephrotoxin or some combination where you might get a spike in damage marker and you might back off in that case. But mostly that won't happen. On the actual injury side of the 2x2, I mean, the classic syndrome of acute tubular necrosis, ATN, has been well defined, and this is another cohort we studied years ago. There's lots of markers that can tell you when you're going to have AKI, creatinine increase, associated with damage marker increase, it's going to get worse and have worse outcomes, and that's clear. And in fact, we've got increasing evidence and validation of the idea that we should start including these damage markers in our classifications. But the fourth quadrant has been less validated, and I think in drug-induced kidney injury, there's a place here for this that mightn't be as secure as a place for other forms of kidney injury, because I think we know this happens. And I just want to show you an example of that. So at subclinical AKI, the creatinine is not increased, but the damage markers are. And when it's drug-induced, we've got growing support for this from cohorts, and I'll show you some of it. First of all, I was involved in a European consortium years ago, which looked primarily at cisplatin, but also at contrast, to identify a useful panel of damage markers, which was selected from dozens more markers, by the EMA and by the FDA for use in early drug development to detect kidney injury. Now, the comparison groups were healthy volunteers versus patients getting these nephrotoxins. So it was a very clean comparison. And they found that added to in green, the functional markers that were already accepted, really, you got this other panel added, and pharma companies have been quietly doing this in phase 1 studies for over a decade now. They've got lots of data, and they haven't shared it. But it's in regulatory packages. And they had approval to add it to phase 2 trials as well. So we went back to the safety data that got that original approval. And Mike Strader, another PhD student who's finishing up in the next few months, did an analysis of the results, and we looked at it slightly differently with this array of markers from these sites, and this has just been published in Kidney International Reports. So there was only 105 patients, but they got a good toxic dose of cisplatin. They got sampling, as you can see, through their first cycle. There were healthy controls and cancer controls, and they had slightly different baseline values. And we found some interesting stuff. First of all, the true gold standard analysis was, in a blinded analysis, of course, wasn't adjudicated. It was, could the markers detect who was treated and who wasn't, who was a control. So cisplatin is such a good nephrotoxin that you could show nice and cleanly that lots of markers could tell you who was exposed to cisplatin. And it could do it earlier than, in some cases than others, but earlier than BUN, earlier than creatinine. Alpha GST actually was the winner on day 1. It was more sensitive than everything. We'll get back to it. It's a bit too sensitive, but it went up first. Serum cystatin and a couple others went up as well, but they went up days before. I think urine NGAL, KIM1 and serum cystatin went up on day 2. BUN and creatinine were later, and quite a flat curve in those cases. So we've got sensitive detection, and we've got early detection, with markers of function and damage. It got more interesting. I was one of the adjudicators that actually looked at the data many years ago. And we adjudicated, first of all, using KDIGO criteria in the patients who were exposed to drug, who got AKI and who didn't by the KDIGO criteria. And this looked like real bronze standard stuff, because there's a lot of increase of biomarker in the groups where the creatinine didn't go up. So when you compare it to the healthy controls or the cancer controls, yeah, there were higher levels in those who got AKI, but actually there were pretty high levels and bad ROC curves in the patients who were treated altogether, because there was no gold standard comparison, and both groups had a lot of biomarker elevation. So it got more interesting. There was a second adjudication, also blinded, where we were allowed to see the creatinine trends. We were also allowed to see all the biomarkers as well. So the rate of AKI went up from about 1/3 to half. and the comparisons got a lot cleaner. And one of the patterns here is there's a lot of positivity for KIM-1 and osteopontin, which is not surprising knowing where magnesium's wasted and where cisplatin does its damage. So in fact, by looking at the comparisons to the control groups, but also looking at the value of adding the damage markers to clinical practice, we've disclosed more AKIs by using both. And there's other data coming. The NIH has done a similar set of analyses. This is the pilot study where they looked at intrathecal, or intrathoracic, I should say, cisplatin during mesothelioma surgery. And they've had very similar findings from this relatively small study. There's spikes at all the same markers we saw that are cisplatin plus or minus operation-induced. And so Swiker just published this. I also adjudicated the FNIH PSTC data where they've done, again, prospective studies in cisplatin and aminoglycosides. They haven't released that analysis and published it, but we're hoping we'll do a combined analysis of all the cisplatin data from both cohorts, and we'll figure this out. In the meantime, pharma is doing this. They've got the qualification, they're doing it in phase 1, they're increasingly doing it in phase 2. They're probably getting experience that we don't have. What about serial samples? And in particular, what about cycle 2? What about cycle 3? I'm in a European consortium where we're actually looking at multi-cycle cisplatin and methotrexate samples. And I think we're going to find what you'd say is obvious. It's not an AKI syndrome, it's an AKD syndrome. And in fact, we've already got a few patients measured, and you can see the sawtooth pattern of their biomarkers going up and not getting back to baseline over the first few cycles. So I think we're going to find that these biomarkers are useful not just as AKI markers, but as AKD markers. But we'll start to figure out how to use them with the clinical information and after insult to get an estimate. I'm also on the governance board for this entity. It's a not-for-profit biomarker data resource that's set up by industry with the Critical Pathway Institute. There's a QR code there, and they will take biomarker data collections from anybody in industry or in academia, and they're doing both, but also give access to people to the data to do research in this area. And we're going to get much accelerated information from there. So I urge you to look at the QR code and call me if you want to talk about it. I'm not going to use any more time to go over it, but just to say, of course, it's not just about phenotyping, functional damage, obstruction. It's not just about doing subsets of functional, subsets of damage. We want subphenotypes and we want drug targets. We've got a few tools coming out, but they're very preliminary, and we don't have time to go into them today. But I hope you found it an interesting talk, and you're convinced that we've got markers now, some of which are clinically available, that can help us detect drug-induced kidney injury and rule out drug-induced kidney injury quite effectively. So I think it's just a matter of getting experience. So thank you for your attention.
Thank you. Yeah, I think we have time for one question. Oh. Yes, please. We have time for one question.
I'm just going to make a comment here. I think you're right, Pat. Biomarkers are really, really going to help us. And sometimes we're going to have to tie the biomarkers together, maybe use a couple different ones. But one biomarker, which I find is amazing, that all the people that I've interacted with rely almost exclusively on creatinine. We know the literature has showed creatinine not to be point on all the time. It depends on the patient. The other thing is, what other biomarker do we have that is real time? How about urine? And how many people are saying, hey, we need to consider urine a biomarker just like we would consider TIM2 and IGFBP7, things like that. So I find it amazing, especially in the United States with our severe nursing shortage, that we're going to expect the nurses to be running in the room to get that urine output every hour. And that's one biomarker that's very helpful to let us know what's going on. I just wonder what you think of that.
No, I mean, I totally accept this. I'm ecumenical about it. I'm not biased. I'll measure anything and I'll use anything. And I think that's what we need to do. So I wouldn't exclude anything at all. Thank you very much.
Thank you.
Okay.